Hi, I'm Dr. Raajit Rampal from Memorial Sloan Kettering Cancer Center in New York, talking briefly to you about how genomics should be utilized in patients with myelofibrosis. So certainly we've seen a explosion in the genomic understanding of MPNs, both from a biological perspective, but also from a clinical perspective in the last 15 years, really since the discovery of the JAK2 mutation. What we've come to understand, and what's I think important, is that the mutations that drive the disease, JAK2, calreticulin, and MPL mutations, are central to the biology of the disease, but they do have different implications with regards to prognostication. And the emerging data suggests that patients with type 1 calreticulin mutations may have a better prognosis overall. However, we do know that there are multiple other mutations that may occur in patients with myelofibrosis, and these clearly have prognostic implications. Mutations such as ASXL1, EZH2, IDH1 and 2, and SRSF2 have been shown over a number of years to have an implication for increasing the risk of disease progression and leukemic transformation. More mutations are being added to the list, such as U2AF1 and NRAS, KRAS mutations. So, when we're assessing a patient clinically, what can we learn and what do we need to do in terms of genetics? Well, I think that it is, without a doubt, in 2020, standard of care to obtain a full genomic assessment of a patient at the time of their initial evaluation. This includes not only the MPN driver mutations, but also the other mutations that we know have a prognostic significance. There are a variety of scoring tools that can be used to integrate this data with historic clinical data that we know has implications for patient outcomes. One such tool is the MIP70 or the MIP70 Plus, and there's also a MIP70 Plus version 2. These tools are readily accessible online, and the data can be inputted into them, and it gives you a relative sense of what the patient's prognosis might be. It does not inform treatment decisions per se, meaning that we really can't decide whether or not a patient needs a JAK inhibitor based on such information. But what the information does tell us is if that a patient has a relatively high risk of disease progression, it may be reasonable to consider that patient for a stem cell transplant. Beyond that information, the information that we get from the genomics may give us some insight as to whether or not a patient is likely to have a prolonged response to ruxolitinib therapy. We know that the presence of certain mutations like ASXL1 predict for a quicker time to treatment failure, as well as the number of mutations. And so those are important things to keep in mind when we look at the genomics. Finally, the outcome of patients after transplant is in part influenced by the genomics, and there are emerging data as well as a scoring risk tool that will give us some sense as to whether or not a patient is at high risk of having non-relapse mortality or even having impaired survival post-transplant. So all of these things are, of course, important in making decisions for our patients. So I think at the end of the day, it's important to have a good understanding of the patient's genomic profile at the time of their initial presentation, and to use validated tools to understand what the implication of those mutations are for a patient's prognosis. And I would also argue that it is a reasonable thing to think about getting serial genomic testing during a patient's course, because the genomics can change and therefore prognosis may change. So in summary, the genomics are an important part of our clinical decision-making with regard to myelofibrosis patients, and I certainly think that they should be considered, without a doubt, standard of care.